Hello everyone. Continuing with the neuropsychiatry series, we'll take up a very important topic which is neuropsychiatric aspects of traumatic brain injury. You have to understand here that it is clinically very important because you will be called for a case which is post traumatic headache, post traumatic seizures, post traumatic personality change. Okay, so in the ER, you will be called for this. So first, clinically important. Second, theoretically, you get a question on this in your paper 4. Okay. Sometimes in paper 2, but majorly in paper 4. So you have to be prepared. In the topic, you must focus upon assessment and management part because that will help you clinically. But then for the sake of completion of the topic and theoretical purposes, we will do everything history, biomarkers, which is an important integral part here. They ask you in your NEET SS exam also about the biomarkers, S100, etc. So we will try to comprehensively cover the topic, but understand that this will help you in many ways. You will go in the basic pathophysiology understanding as well, which will require a bit of knowledge of your pathology classes in the MBBS. Do not get bogged down by the extra material that I'm going to give you, just that it is required. So, and you can cherry pick the topics which you have to write in your theory exam. If it is a 5 marker, you can just make a summary of the note that I'll be giving you, and then you can write the answer. And if it is a 10 marker, then this will suffice. Fine. So let's begin with the topic: neuropsychiatric aspects of traumatic brain injury. See, we understand by the topic that we are talking about brain. Okay. What has happened to the brain? There is an injury that has taken place. What is injury? It is an external physical force which leads to damage. Damage what? Damaging a particular brain area or certain brain areas. It can be a structural damage or a functional damage. Basically, it can be a temporary damage or a permanent damage. And further, it can be a structural damage or a functional damage. Here also, structural damage or a functional damage. Understood? You need not take notes here. I'll give you the notes. Just that try to understand what we are going to deal with. So, traumatic brain injury. Brain is being damaged by an external force. Okay. Okay. So, when we are saying trauma, this trauma can be mild, moderate, or severe. Basically, the intensity of the what we say, the injury, it can be either mild, moderate, or severe. And why is it important? Why is it important to classify? Because all three, this mild, moderate, severe, will have different survival consequences. Okay. Okay. And how we know that the trauma can be mild, moderate, severe? It will depend on what? It depends on your mode of injury, how the injury has taken place. Okay. If it is a high velocity crash, if it is a gunshot wound, if it is a stab wound, okay, then only we can understand the trauma is mild, moderate, or severe. And why important? Because of the survival chances are different for each. Fine. This is just the very basic that you must know and understand. And this, ultimately, this trauma can lead to the most deadly consequence, which is death. So that is why this topic becomes important. Here you need to understand that we are again and again saying trauma. Trauma can be, trauma means head injury here. For all practical purposes, here in this particular topic, trauma means head injury we are talking about. So head injury can be closed or penetrating. Close like in the road traffic accidents, the automobile accidents that occur, then any assaults are there, physical fights, okay, they are there. Then elderly people especially, they get closed head injury due to falls. Okay, penetrating, as we see in the gunshot wound, stab wound. Fine, understood. So in closed, what we know is, what is the characteristic of a closed injury? That head is struck, head is struck, but skull is intact. So if someone asks you what is the major difference between the closed and penetrating head injury, then in closed, the skull is intact, whereas in penetrating, the object pierces the skull. Skull. Okay. So in closed, what is happening is, this is the skull outer covering. This is the brain here. In closed, the force is on the skull, but it is intact. But what happens in penetrating? The skull is pierced. Skull is pierced. Okay. This is penetrating and this is closed. Fine. So that is why closed is also known as non-penetrating, or you must know blunt force injury. Telling you because the question in your exam can be neuropsychiatric aspects of the blunt force traumatic brain injury. So you must not get confused. Fine, understood. So this is basic. So we understood that traumatic brain injury basics. Then what is trauma? Now let's understand that how the injury forms. Okay, and after this we can start writing. So what happens is, there is a trauma, okay, which we will call primary injury. Let's say someone has hit the other person by a stick on head. Okay, so this is primary injury. This leads to cerebral ischemia, inflammation due to the stimulation of pro-inflammatory cytokines, and redox imbalance. Redox imbalance. Basically, I'm going to talk about the oxidative stress. Okay, reduction and oxidation. Fine. So this is there. All this ultimately leads to what? Blood-brain barrier disruption, or we say alteration. That is, we know what has occurred: altered blood flow. Altered blood flow has taken place. This will lead to what? This will lead to one side neuronal and glial damage. That is, one side it will lead to neurotoxicity, and on other side it will lead to oxidative stress. Oxidative stress. Okay, oxidative stress. So what happens? Primary injury leads to disruption of the blood brain barrier, then it leads to the neurotoxicity and oxidative stress. Understood? This is basic. Okay, then comes the phase of secondary injury. Secondary injury occurs hours or days later. What all it includes is, by this time the oxidative stress has increased. Okay, oxidative stress has increased. You must have learnt in your pathology that there is a what we say reflux, calcium reflux, which causes injury. So there is a modified calcium release which leads to reflux injury. Then inflammation is increased. Then axonal damage is there. What all this leads to? Now this leads to cellular death, impaired neuronal circuits, impaired synaptic transmission, and impaired synaptic plasticity. Okay, so now the functional effects are changing. The functional effects are being changing for worse, okay. And how clinically we see them. So the effects of primary and secondary changes, how it appears to us clinically or behaviorally. Okay, so it can present as post traumatic. PT is post traumatic. It can present to us as post traumatic headache, post traumatic depression, post traumatic personality change, post traumatic anxiety, post traumatic aggression. Okay, then the person can complain deficit in attention, cognition, any sensory processings, deficit in communication. Okay, so these are the basic symptoms that we encounter clinically due to this injury. Okay, understood. So this is just the basic that I wanted to tell you about the traumatic brain injury. From here we can start writing. Okay, so let's just conceptualize it. Someone has hit the other person with a stick. Okay, so that means there is an external physical force which has led to damage. Okay, certain areas of brain, they undergo damage. Okay, this will lead to what? This will lead to either temporary change or permanent change in the structure or function. Okay, so primary injury, then secondary injury, and then cell death will occur. Fine. So then we classified the trauma. It can be closed, penetrating. I've made you understand this. So coming to the pathophysiology. So when the uh, person is hit with the stick, that is primary injury takes place, there is blood-brain barrier disruption, which leads to neurotoxicity and oxidative stress. Okay, this is followed by secondary injury, where oxidative stress increases, calcium release is there, which causes a reflux injury. Then inflammation also increases, basically the neuro axonal damage is there, basically the neurotoxicity also increases. And ultimately, what are the effects that we see? Cell death, impaired neuronal circuit, impaired synaptic transmission, and plasticity. Clinically, this is undergoing pathology, the pathology in the brain. But clinically, what we see? Post-traumatic headache, depression, anxiety, aggression, personality change, and then deficits in attention, cognition, sensory processing, communication. These kind of features we see clinically or behaviorally. This is the just the basic. So now let's start with our main topic, that is neuropsychiatric aspects of TBI. So let's begin with the definitions first. See, definitions, there are many definitions. You can search on Google traumatic brain injury definitions. You will get many articles with various bodies giving various definitions. Okay, we'll start with the most comprehensive definition. Okay, given by Brain Injury Association of America. This is the most comprehensive, I would say. It says that traumatic brain injury is a non-degenerative, non-congenital insult to the brain. So it has clearly, what we say, clarified that it is not congenital and not due to a degenerative process. Okay, brain injury is there, but it is not by birth or not due to any degenerative process that is ongoing in the body. So TBI is a non-degenerative, non-congenital insult to the brain which occurs due to an external force, usually mechanical, okay, possibly leading to temporary or permanent impairment of cognitive, physical, and psychosocial functions with an associated diminished or altered state of consciousness. So it has included everything. Insult to the brain, how an insult? A non-degenerative and a non-congenital insult. How occurring? External mechanical force. which will lead to temporary or permanent damage to the cognitive, physical, and psychosocial function. So it has included the functionality, okay, and altered state of consciousness. So I would say the one of the most comprehensive definitions that we'll find. Okay, see why the definitions is not fixed, because it depends on the circumstances or the severity, basically, about the TBI. Okay, so there will be various definitions that will come forward. Okay, like CDC has given one of the simpler definitions. It says that if there is a disruption in normal functionality of the brain, which is caused due to any bump, these words are mentioned, please write: bump, bolt, bump, blow, or jolt, okay, to the head, or penetrating head injury. Penetrating head injury. So in comparison to the previous definition, this is a relatively simpler definition, okay, by CDC, and it focuses on the head, okay. Then there is another definition by DCAWG, okay. This is your demographic clinical assessment working group, okay. It more focuses on the brain. It says that TBI is alteration in the brain function or any other evidence of brain pathology which is caused due to an outside force, okay. Now we have seen the definitions by various bodies. Your DSM has also given a definition, and if you want, you can remember only this one, because DSM, the teachers, they will understand that you have read DSM, okay. DSM says that TBI is a brain trauma with certain specific characteristics like any one of the following should be present. First is, either after the brain trauma there should be loss of consciousness, post-traumatic amnesia, loss of consciousness, post-traumatic amnesia, or there should be disorientation, confusion, or any neurological signs we should get. Neurological signs can be either we can get something positive on the neuroimaging, or we can see any worsening of pre-existing seizures, okay. Then there can be any focal neurological deficits that we can find: anosmia, hemiparesis, anything, okay. So any one of the following, anyone, okay. So these are various definitions. According to your need, you can use any one, okay. I would for exam purposes, DSM would be better, okay. Then there in the textbook you will find certain words like focal lesion. So you can understand the definition of focal lesion as well. Basically, focal lesion, coup injury, and contrecoup. These are three words that you should basically understand only, okay. So focal lesions, what do you mean by a focal lesion? It means that there is a direct blow to the head. Fine, focal. I have hit at this place. So this is my focal lesion. Okay. So direct blow to the head. Direct blow to the head. This includes everything. Okay. Laceration of the head, contusion. It includes your intracranial hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, and ischemic infarct. Fine. So focal lesion will include everything. Okay. In contusion, remember one thing that I want to give you here is There are two types of injury. One is coup, one is contrecoup. Let's say this is the head. If the person has got hit here, okay, and the impact or the injury has also occurred here, so the injury takes place directly beneath the place of impact. This is what? This is your coup injury. Whereas if the injury takes place on the contralateral side, okay, basically contralateral to the injury side, to the impact side. The injury takes place contralateral to the impact side. It is known as the contrecoup injury. Contrecoup injury. Okay. Okay. And here you need to remember certain things. Till here, it's easy. Certain MCQs or certain more understanding for you. What is the most common site for contrecoup injury? Tell me, most common site? The most common site is orbitofrontal area. Okay, and certain temporal tips as well. The temporal bone protuberances, certain part of it, but most common site is orbitofrontal area. Remember, okay, this will help you in your MCQ. So most common site of your contrecoup injury is orbitofrontal area. Okay, basically what happens is when the injury occurs, the acceleration and deceleration, it tries to balance itself and it gives its most of the impact on the bony protuberance of the skull in this area. Okay, and that is why it is the most common site for contrecoup injury. Okay, so if someone asks you why, because because the acceleration tries to balance the deceleration. When someone hits something hits, so this acceleration is stopped by the deceleration or the effort by the skull as well, na? So when this tries to balance each other, so the most of the impact goes to this area or orbitofrontal area. Fine. Now one more MCQ for you. If there is an injury to the bilateral orbitofrontal area, bilateral orbitofrontal area is injured, what is the syndrome associated? It is frontal behavioral discontrol syndrome. So they can ask you directly as well that in bilateral contrecoup injury, okay, which syndrome do you see? It is frontal behavioral discontrol syndrome. Okay, understood? So we have seen the definitions. We have seen what? We have seen the frontal behavioral discontrol syndrome and orbitofrontal area. We have covered your MCQs as well here. Fine. Now we see the severity grading. See, when there is an impact, it can be mild, moderate, or severe. Basically, the injury can be mild, moderate, severe. And earlier, as I explained you, all three will have different survival consequences. Obviously, mild will have more, moderate, bit lesser, and severe and very severe will be the least. Actually, there are two gradings. One says mild, moderate, severe, very severe. The other says mild, moderate, severe. First, we will see the mild, moderate, severe, and very severe. So our classification is mild, moderate, severe, and very severe. Okay, Mayo. It is the elaboration of the Mayo classification. Okay, so mild, moderate, severe, very severe. What is the criteria? Criteria is post-traumatic amnesia. Post-traumatic amnesia. Okay, what is post-traumatic amnesia? I've talked about it 2-3 times. What is post-traumatic amnesia? See, whenever there is a trauma, let's say on 1st January exactly at 10 a.m. Exactly at 10 a.m. 1st January, person suffered road traffic accident. Okay. Thereafter, he has anterograde amnesia for 24 hours. And after 24 hours, he's able to recall. He's able to clearly memorize. Okay. Basically, normal memory has returned. So this period from the trauma till the period of returning of normal memory is anterograde amnesia, and in this case it is known as post-traumatic amnesia. So what is post-traumatic amnesia? Post-traumatic amnesia is the anterograde amnesia from the event, from the injury till the period where from the injury till the normal memory recovers. Okay, normal memory recovers. Okay. Achha, what is retrograde amnesia? Retrograde amnesia is just defining here, okay, for your understanding. This is his last clearly recalled memory. Okay, so the period between last clearly recalled memory and the injury, that is your retrograde amnesia, the period of retrograde amnesia. Okay, understood? Understood. So in severity grading, we use post-traumatic amnesia. If post-traumatic amnesia is less than 60 minutes, mild, then 1 to 24 hours, moderate, then 24 hours to 7 days, severe, then more than 7 days, very severe. The another classification that we will see, it has merged the moderate severe thing. We will see that. Okay. Then they have commented on the functional outcome here. They say that in mild, the person can return to work in less than 1 month. Okay. In moderate, it can return to work to less than 2 months. In severe, it can be within 4 months, and in very severe, he might require more than 1 year. Okay, so this is first severity grading that you need to understand, where we have classified as mild, moderate, severe, and very severe. Less than 60 minutes, 1 to 24 hours, 24 hours to 7 days, more than 7 days. The level of post-traumatic amnesia. So similarly, the functional outcome will be best for mild and least for the very severe. Okay, now comes your second severity rating. So in this we see mild, moderate, and severe. Okay, and what are the variables? Variables are about the imaging, about loss of consciousness, altered mental state, post-traumatic amnesia, and Glasgow Coma Scale. See, now you understand that in mild it will be the best of everything, then moderate, and then severe. Okay. So in mild, the neuroimaging would be normal, whereas in moderate, it can be normal or abnormal, and severe also normal or abnormal, not necessarily abnormal. First point to remember for your MCQ if you want. Not necessarily abnormal. Fine. Then loss of consciousness. It is very less, like 0 to 30 minutes. Okay. Here it is more than 24 hours. And between 30 minutes to 24 hours is moderate. Fine. Then comes your altered mental state. Altered mental state, see, for 1 day, it is mild. If after injury there is an altered mental state up to 1 day, it is fine. Okay. And more than 1 day, it can be moderate or severe. Moderate or severe. Okay. Now comes post-traumatic amnesia. So here it is 0 to 1 day. 0 to 1 day. So this is clubbed. Mild and moderate is clubbed. Okay. 0 to 1 day. Here it is 1 day to 7 days. Here it is more than 7 days. Okay. So this you have to remember. Post-traumatic amnesia. Period of post-traumatic amnesia. Okay. And obviously GCS. GCS will be best here, 13 to 15, 9 to 12, less than 9. Less than 9. Easy. It is not something that you need to mug up. You can just remember the variables here, variables on this side, and the categorization on the other side, mild, moderate, and severe. Okay, fine. Then there is one association which is American College of Rehabilitative Medicine. Okay, it has given its own criteria. It says that mild TBI is traumatic brain injury which induces physiological brain dysfunction. It is talking about mild, okay, with following. It says if there is any period of loss of consciousness, any amnesia, basically any loss of memory for the events immediately before or after the accident, okay, and focal neurological deficits which may or may not be transient. Okay, then it has also put the secondary criteria for mild. It says that GCS should not be less than 12, should not be less than 12. Okay, CT scan should be normal, and there should be nothing which should be operative. So no operative lesions should be there in the brain. Okay, this is American College of Rehabilitative Medicine, which has defined mild traumatic brain injury. They have also given criteria for moderate traumatic brain injury. It says that GCS should be between 9 to 12 or higher. Then the length of stay of person should be at least 48 hours. At least 48 hours. Then if there is any operative intracranial lesion or abnormal CT scan finding. Okay, any one. So it will fall in moderate. So this is ACRM criteria for mild and moderate TBI. You can remember either this one or this one. This you can skip, the American College of Rehabilitative Medicine. Okay, so these are your definitions. So what we saw, we started with the most comprehensive definition. Then we came to the simpler definitions. Okay, then we came to the DSM-5 definition. Then we understood the coup injury, counter coup injury, saw certain MCQs, then severity grading. Okay,